All right, now I'd like to welcome to the stage Allison Simpson. She's a community navigator here at UPMC, working with Gender and Sexual Development Program and the Center for Adolescence and Young Adult Health at UPMC Children's. Allison, come on up, and she's going to be talking about fertility in the LGBTQAI community.
Hello. I wanted to start with a shout out to all the patient and care navigators who have either presented or attended this conference. While my position does involve some patient interaction, I actually support parents primarily. It's kind of the inverse of that. As a community navigator, a unique position currently in the entire UPMC health system, I'm really helping the health system navigate gender diversity and the gender diverse and transgender community. So this is a very, very broad topic, so I'm going to try to do it justice, but I think most of us are familiar with the LGBTQIA+ acronym, and this is a brief sort of explanation of that. But we're really talking about a bunch of different things. Even though this is a collective movement, we have aspects of LGBT that are sexual orientation or attraction, such as the identities of lesbian, gay, bisexual, asexual, and queer. We have gender identity, which is about your internal sense of self, where we have transgender, non-binary, agender, and also queer. And people can question both of these things. We also have, under the transgender umbrella, the concept of gender expression, which is not really relevant to fertility, so I'm not going to talk too much about it. And then we have the biological factor, the biological traits that are most important for transgender and intersex individuals. So the biological spectrum, which you may not have been taught in med school, is based on this refutation of this idea that we are absolutely dimorphic. And this is a quote from Blacklist from the turn of the millennium that says that that's really a Platonic ideal. And I'm not going to get too far into it. This is actually a very simplified and shortened version of a very long table from research by Stracol J. et al. From 2020 that really delves into the fact that while many of us have many of the traits that are typically associated with what we call a typical male and typical female, quite a larger number of us don't have all the traits that are typically associated. And there's a continuum between or around these typical states. Some of the areas in this continuum are in fact intersex traits and may be related to differences of sexual development, and others are really just generally distributed across the entire population of humanity. Why this is important in the context of gender identity, which is going to be the focus of this talk, is that we have this misguided idea that there is such a thing as biological essentialism. If you're born with a penis, you are a boy. If you're born with a vagina, you are a girl. And in reality, that is not always the case. In fact, more common than any of us would think, you may have a different genotype. You may, in fact, have a phenotype that does not match what is, the external genitalia found at birth. And often, when there is some ambiguity in this area, the decision to assign a male or female is based on a measurement of the length of the erectile tissue, either the phallus or the clitoris. Most transgender people are not tested for differences of sexual development, because unless you have a definitive difference, which either shows up at birth or at the onset of puberty, or possibly when you are trying to have your own family later in life, we generally don't look for that. It's not something that we look for. But we have many, many occasions, many individuals from the transgender and gender diverse community who have traits that don't fit neatly into either of these categories. Now, I'll briefly talk about the LGBTQ and A impact of fertility. The vast majority of people who have those identities, which are based around sexual attraction, are cisgender, not transgender. That means that they have the same reproduction options that the vast majority of us do. There are some additional considerations, of course. There's a higher prevalence of surrogacy, there's a higher prevalence of donor tissue, there's a higher prevalence of I lose words sometimes. There's a higher incidence of fertilization that is not traditional. But when it comes to gender identity, there are both identity-related issues and biological-related issues. And I'm not going to talk too much about intersex conditions because I believe that's the next talk. Oops. There we go. So before we get into some of those details, why is this important? As far as most of the studies we have show, it's a very, very small population. But we've long suspected that due to the way the questions are asked, due to the stigma and discrimination that most of the members of the gender diverse community experience, there's vast underreporting. So the prevalence from a study in 2017 came up with a figure, 2.7% of the population is gender diverse or transgender. And that's a range of identities in there. Not everybody in that population identifies as transgender, but that was the primary identifying factor. And we have clinics across the country. There are transgender people everywhere. You can see that there are some dead zones. And again, this is older data. Prior to this, the numbers that we had from studies were sometimes less than 1%. I believe there was a recent study in Canada that came out with a figure of, I believe, 0.3% of the population of Canada. We now have evidence that that is not accurate. And in fact, the new data comes from, amongst other places, Pittsburgh. One of my colleagues led a study that took place in the Pittsburgh School District, roughly 13 high schools, as part of the biannual youth risk assessment survey, where they found a different way to ask about gender identity. They asked in a two-step methodology and a methodology that gave a wide range of terms, allowing write-in as well, and said, check all that apply. And suddenly we got numbers that were significantly higher. In that particular study, 9.2% identified as gender diverse. Not all of those individuals would identify as transgender. Not all of those individuals would seek treatment or transition care, but it's still a very significant number. And I think this is important to understand. This is just a brief summary of some of the tables from there. This was across all racial and ethnic demographics. In fact, in this particular school district, as a percentage of the overall population of that particular identity, the majority were in fact black, and the minority were white. Also very interesting was the breakdown between binary identities, and I'll talk more about that in a minute, of either transmasculine or male identity, binary, transfeminine or female identity versus non-binary. And the statistics we got were roughly a split between, let's see, what is the overall? It was roughly a 30% transmasculine, 30% non-binary, and I believe 39% transfeminine. And why that's significant is in gender clinics here in Pittsburgh and all the major gender clinics around the country, we are predominantly seeing transmasculine and non-binary individuals. There are a lot of theories as to why this is, but the evidence suggests that there's a large community of transfeminine people who are not actually able to access care. So let's jump back to gender identity. One of the things that we've learned from the identity development in children is that the concepts of gender and the consistency of gender identity developed roughly between the ages of 3 and 6. Now, the labeling and identifying of other people and potentially yourself, 2 to 3.5 years is fairly consistent. That tends to stabilize over time. And then by 6, we generally accept that gender identity, whatever it is fixed. Now, that doesn't necessarily mean that the child fully understands their gender identity. They may very well be projecting a gender identity that they think they're supposed to, and may come to understand that identity as they grow older. There are various catalyst points. One, of course, is puberty. Sometimes it's later in life, and sometimes people don't actually realize until they are much older. But we're finding increasingly that younger children, the youngest we've had at the gender clinic I work at has been 4, are finding information and enough self-confidence to say, hey, this is me, I'm actually not, I'm a girl, or I'm not a boy, I'm a girl, I'm not a girl, I'm a boy. And these early identities tend to be binary. So let's place that in the context of gender diversity. So there's a lot of graphics that lead up to this, so I'm just jumping to the chase here. We recognize 2 basic axes in gender diversity, and this, like any other depiction, is a vast simplification of very complex information. Identity, and even gender identity, is so specific that you could say that every one of us has their own unique one. But we have an axis of binary identity, which tends to run from masculine to feminine, and we have another axis of non-binary identity. And in this particular depiction, you know, those of us who identify with the sex assigned at birth, those of us who are cisgender, who live congruent lives, would be on either the masculine or feminine spectrums. And in that sort of middle space, we've expanded it to include one type of non-binary identity, which is that both or mixed identity. And all of those identities generally fall on what we're now calling the binary gender spectrum, which you may have heard of the gender spectrum before. But there are also non-binary individuals who do not relate to or do not see themselves inside the binary at all. And so we have that third dimension there to allow for people who, many of whom this incorporates agender, or the absence of gender as we understand it, identities, and identities that are just inexplicable because we don't have the language for them. These individuals do report a very strong sense of gender, but they generally borrow words. I've heard gender identities of peach, or tea, or whatever. The language doesn't exist for those identities, but they're just as real. And so when we're looking at this, the major difference in binary identities for transgender individuals who may or may not also identify as non-binary, these are 2 separate continuums, is that the sex they are assigned at birth is generally, if they're binary, on the opposite side of that binary spectrum to the one that they were assigned, if their gender identity is different. There are degrees to all of this. There are degrees to how strongly a person feels gender incongruity. So let's talk a little bit about how this impacts fertility. So 30 years ago, we were under an old model of gatekeeping that basically said there is one way to transition, and there's one way to be. And if you do not fit this definition, then you will not have access to care. And medical and surgical procedures were required, and if you did not have them, you could not legally transition. So there was this built-in assumption, unless you were older and you've already had children, that you would be infertile after the gonadectomy or hysterectomy or any of the other parts. Things have changed a lot. We now use an informed consent model where all of these medical and surgical therapies and procedures are optional. But with younger and younger children being able to come out, we now have the option of using hormone-blocking GnRH agonists at the onset of puberty, which is Tanner stage 2. and gender-affirming hormone therapy in teens. Now, according to the World Professional Association for Transgender Health, this current standard is no gender-affirming hormones before the age of 16. In practice, there are many benefits for congruent with peer group hormone therapy, and I know that there have been individualized cases where we have started as young as 14, but generally 15 or 16. And the important difference between the old gatekeeping model and the current informed consent model is that therapy is strongly encouraged as a support, but it is not required. And this is important because under our current model and the seventh version of the standard of care, which is currently in effect, you cannot access care without a diagnosis. Many of those diagnoses come from mental health. The DSM-5 has the gender dysphoria diagnosis. WPATH also has the gender dysphoria diagnosis, and these are unfortunately not identical. But we're moving to a new model. WPATH Standards of Care 8 are expected out later this year and have been thoroughly reviewed and are being finalized at this time. And one of the big moves is that they are moving to the World Health Organization's ICD-11 standard, which I believe has not yet become, but will soon become the standard in the US as soon as and Canada as soon as it's approved. And under ICD-11, gender incongruence, which leads to gender dysphoria, is no longer considered a mental health or medical condition. In fact, it has been moved into a category called conditions that can benefit from medical intervention, not unlike pregnancy. And WPATH will be using the diagnostic criteria for gender incongruence as part of their standard. And these standards of care form the basis for our practice guidelines for all of the major medical associations in the US and also, I believe, in Canada. So let's talk a little bit about this transition for adolescents and young adults. Now, under our current model, all of this is opt-in. You do not have to do anything in any particular order to access care or to be considered living in your authentic gender identity. But typically, when we have younger children come out to us, they are encouraged to pursue social transition. This is controversial at the moment, but all of the evidence that we have and all of the major guidelines suggest that social transition is beneficial. And it's important to note, because there is a lot of misinformation out there, that there are no medical interventions before the onset of puberty at 10 or 2. What we look for is that the individual is insistent in proclaiming their gender identity, persistent, and consistent. And if somebody who transitions between the age of 4 and that onset of puberty, or sometimes it's possible they could be younger, and they are insistent, persistent, and consistent, it's almost guaranteed that they're going to move on to the next stage, which is the first type of medical transition is that of the GnRH agonist puberty blockade. And the reason we do this is, while we have a lot of evidence to suggest that mature minors can make these sort of decisions, we also want them to be sure. Because puberty blockers are completely reversible. We have 40 years of history where they've been used for precocious puberty, to treat endometriosis. We have a long history of safety. They hit pause. They hit pause, and for generally 2, maybe 3 years, puberty is on hold. And that gives the child time to mature, to think over, to do some soul searching, to really, to the best of their knowledge, make a decision about whether they want to move forward into the less reversible treatments. For someone who has this history of insistent, persistent, consistent identity, it is very rare for them not to move to that next stage. But if they were to choose to do so and they stop puberty blockers, puberty would resume as normal based on endogenous hormones. But once we add in gender-affirming hormone therapy, from between 14 and 16, or whenever the person, if they come out later in life, comes out, those changes tend to be likely to definitely permanent. And one of the impacts, of course, is fertility. It has become very important in gender-affirming care that we talk about fertility. Recently, I was part of a rewriting of our informed consent guidelines, and we have fertility as a high line item. These are all the things that a provider has to discuss with a family and a young person who's under the age of majority. And we treat fertility slightly differently based on the person's sex assigned at birth, because we know that the longer that a person assigned male at birth is on estrogen and other feminizing hormone therapies, the higher the likelihood they will be permanently sterile. However, the data actually shows that even after a prolonged period on testosterone, transgender people who are assigned female at birth are and have successfully become pregnant and had live birth. So we list them differently. One, high likelihood, the other, may cause infertility. Now, for children who have gone through this process of being consistent all the way, and they start these gender-affirming hormones, they are much in the same boat as any other prepubescent with regards to fertility. They may not have mature tissues. They may not have any viable germ cells that have matured. So they have as the same basic therapies that for anyone else who is facing fertility preservation as a prepubescent. All of gender-affirming care is done from a harm reduction basis. And while it may seem relatively simple to suggest that they take some time and go off blockers before they start, and so potentially mature slightly, the harm and the fear of the changes that may happen, even in a period as short as 6 months, is so great that this is generally not standard of care. Regardless of the decisions around medical puberty, regardless of the age a person starts, if they have not yet had children and they opt to have surgical transition, gender-affirming surgeries, especially those that affect the reproductive system, well, then infertility is permanently induced. And is a very, very hard decision for a lot of transgender people between, can I live authentically, or should I hold off a little bit longer and maybe bank some material so that I have options? For those who transition much later in life, there is a high probability that they have already had children. And there are many older transgender people who do have kids. But for somebody who is in their late teens, early 20s, this is a very hard decision. Regardless of whether somebody has been on puberty blockade and has started hormones or is about to start hormones, or have had some pubertal development and decide to transition later in life, generally speaking, for the same issues of trauma and incongruence, the standard collection methods don't usually work. As I mentioned, if you have been on blockade and you go straight into gender-affirming hormones, then you have the same issues with fertility preservation as prepubescent cancer survivors or others who are potentially going to lose their fertility due to medical treatment. And I've covered most of this already, but that really leaves us with tissue preservation. And you've heard a lot about that in the last few days. We have limitations on that. There have been few instances where we've been able to actually recover viable germ cells at this moment. So it's experimental. So this is sort of a least worst option for these kids. But the fact that these standard collection methods may be incongruent is a barrier to care for many transgender individuals, regardless of where they are in puberty. And again, this should be an option, minimally invasive tissue sampling and preservation may be a viable option for them as well. The degree to which a person has what we call physical dysphoria and feels that incongruence in their bodies varies. And so there are some transgender individuals who will not have these issues at all and will be willing to do this, but they tend to be older. Okay. So this is about fertility, not just fertility preservation. So we're going to dive into something that is probably a little bit controversial, raises a lot of ethical questions. But starting with the release of Jones et al. In 2018, mostly published in 2019, so that's when most community members actually became aware of it, there was a study that evaluated whether uterine transplantation, which at the time there had been 42 procedures in the world and 12 live births recorded, was an option for transgender women. Now, most of these UTX procedures had been done on women who, for various reasons, did not possess a uterus. And they involved essentially transplanting the entire reproductive system, including vaginal tissue, the initiation of menses, and following that, successful implantation and gestation and delivery. And this preliminary paper discovered that, yes, there are definitely anatomical, hormonal, fertility, and obstetric challenges, but no overwhelming argument against performing this. And they were evaluating this as part of GRS, that's gender reconstructive, or what we prefer to call gender-affirming surgeries. It's important to understand that in most of these original UTX procedures, they were temporary. The idea being that you would implant and you would have the transplant long enough to conceive, carry, and deliver, but then due to limitations of rejection medicine, you would have that all removed, usually as part of the C-section, which was the standard way of delivery. So the idea that this would become something more permanent was somewhat wishful thinking, but that's what they were looking at. And they said there's a need for more research. So in 2021, a paper by Jerome and a large number of other individuals did a full proof of concept evaluation, looking at every single issue and challenge that had been raised, and finding solutions to pretty much all of them. While there are definitely differences between fully developed male and female bodies, in the larger scheme of things, there are analogs for everything. We all develop from the same basic material in different directions. And so we were able to find solutions to things like how do you provide sufficient blood flow for the uterus to keep it alive? How do you secure that inside the abdomen? And how do you ensure that all of the necessary biology supports the actual implantation and gestation and so on? You can tell I'm not really an expert in this area. But again, the focus was on how could we incorporate this as a part of gender-affirming surgeries. Now, gender-affirming surgeries are generally very complicated to begin with. They involve urology, they involve, shall we say, manipulation of tissue, and they tend to be fairly long. And so when you introduce the addition of transplantation, the complexity goes up greatly. But one area that had not been looked at before in any serious way was, could the donors be live donors? Because in the original study, the conclusion was that they would have to be cadaver-based donors or from individuals who were no longer alive, right? So live donation has been something the community has talked about for decades. It was really seen as magical thinking. This would be a live donation from a person who was assigned female at birth but identified as a transgender man. And they said, well, I have these parts, I don't want them. You want them, you need them, so what if I gave them to you? How would that work? And apparently, based on their research, this is actually viable. Finally, in the same year, Jones and a different group of collaborators did a study around the perceptions and motivations for uterus transplant in transgender women. Anecdotally, many, but not all, transgender women, especially those who transitioned younger in life, have expressed an interest in having children in a way that is congruent for their own bodies. But it was still surprising to see the data. It was a fairly large study, as transgender studies go, 182 transgender women, 60% of which were aged in the ideal 20 to 29 age range, and most had no children. 94% indicated they had a desire for children. Most of them reacted very favorably, something like 90 to 80% in favor of various aspects of having a vaginal transplant, having a uterine transplant, and in the UTX, this would all be part of the same transplant. The tissue would be preserved from the parts of the vagina all the way to the uterus. Having menstruation, experiencing gestation and carrying a life inside them. And overall, these results suggested that most transgender women would choose to have female physiological experiences, such as menstruation, gestation, as well as potentially having a physiologically functioning transplanted vagina. And they also stated that if they had that option, it would also increase their desire for fertility preservation. The model they were looking at was permanent transplantation. Now, one of the big drawbacks to the model that was in use back in 2018 was it had to be temporary, and unfortunately, when we're talking about transplant as a part of gender-affirming surgeries, the idea that some of that surgery would then be undone is pretty traumatizing. You will lose part of your vagina is not really a good selling point to someone who wants to live a full life. But as anti-rejection medications have improved, I think it looks like we are potentially on the road to where permanent transplant may be an option. And as this is pretty much the end of my talk, I wanted to give you one more perspective. I actually transitioned as a transgender youth 30 years ago, at a time when we didn't even use the word transgender very much. And I kept a diary, and about 5 years ago, I looked back on that diary, and I was actually surprised to see that one of the biggest considerations I had at the age of 20 was the potential for pregnancy. And I wrote in that diary, well, I'll give the medical community 20 years. I'm sure they'll figure it out by then. 30 years later, one of the main reasons I do the work I do is a desire to push us in that direction. And the data now supports that this is something that members of my community desperately want if it were offered to them. I have included references to all of the major papers that I drew from, and I don't know if they have access to the PowerPoint, but if you would like a copy of those references, you can email me, and I'm open to any questions you might have.
And we'll take questions now.
Hi, Allison. How's it going? I have a couple.
Okay.
I crowdsourced from a Discord that I'm in with a bunch of queer individuals. Some of them are in the area. And one of the questions that came up was on queer inclusive sex educators. I think this individual was really interested in knowing who's available in the Pittsburgh area, but also what's your experience with training sex educators with especially in a pediatric population, and how do we, you went through this wonderful presentation on the continuum of identities, and how do we get that information more widespread?
Well, I'll be honest, training in gender diversity and cultural competency is a large part of my job, but the people who I train are medical providers and staff primarily. I mean, our long-term goal at UPMC is to train all 90,000+ employees. And that has been stated by management. It's a huge task. No one person can do that. We do offer training to schools, but sex education specifically is not something that I think we have contemplated offering. You know, a lot of the challenges we have are just getting people to understand the concepts of gender diversity, and that's usually, you know, to get school boards to actually support these kids. And there's a lot of misinformation out there, so a large part of our role is to sort of debunk the bad, the misquoted, or the outright fabricated information, and replace it with science, peer-reviewed science evidence-based information. So I don't really know if that's something that we can offer, but our services are available to pretty much anyone who asks it. I know, you know, in our clinic, which is the adolescent and young adult clinic, a lot of our work is around sexual health. So it does overlap somewhat with the work we do.
Allison, hi.
Hello.
I'm Emily Johnson. I'm the next speaker, and I don't want to steal your thunder, but I do want to mention that the health educator at Lurie in the Gendered Sex Development Program is an intersex, queer, non-binary, transgender person, and I'm sure they would be happy to connect if that would be useful. So I can provide their information. If
I would love that.
Yeah, if you would like after my talk.
That's awesome.
I think in the interest of time, we'll take 2 more questions.
Okay, so and then my last one has to do with insurance.
Mm-hmm.
Whether or not insurance views a transition as being the discussion about whether or not you can get insurance to cover something when insurance might view it as voluntary sterilization. And so how do you navigate that? Are there ways around that? What are there guides for, finding an insurance company that could potentially cover?
So there's a lot of pressure on insurance companies to cover more and more transgender-related procedures as medically necessary. In fact, the mandate from and the position of the World Professional Association is that anything that helps achieve gender congruence is potentially medically necessary. Obviously, insurance companies have been very resistant to this idea. We are seeing signs that things that traditionally have been written off as cosmetic are now being covered. But the gender identity, just where it's something like fertility preservation, the bar is already high for that for cisgender populations. Mm-hmm. It is even higher for those who are gender diverse. And even when there is coverage, whether it's mandated or it's provided, you pay for it, most transgender people still have to fight to actually get it. So it's a major area of advocacy. I have personally done advocacy inside our system to get coverage, and successfully so, but it took 3 years. We do offer coverage of a much wider range of services than many insurance companies do. And a large part of that is that they have the choice of which version of the standards of care to follow. Colleagues in other parts of the country have reported, we just got them to accept standard of care 6, which was introduced in 1996. So there are significant challenges, but I think we're starting to see signs that things are getting better. And honestly, the ACA was the biggest boost we've had in decades.
Thank you so much.
Thank you.
Thank you for your talk and for sharing your own story. There's been several publications lately with conflicting results in terms of desire for fertility preservation. And we know we can't compare what we know about the cancer population, which is there's high amounts of regret from people who did not choose to do fertility preservation at a time when it was most efficacious. We can't make those assumptions, but I'm wondering if you have a sense of how we can really get information among youth who might not be future forward thinking, might be completely focused on making this transition, and if there's going to be regret later that at an optimal time they didn't choose preservation.
That's a good question. I mean, you know, I personally come from a generation where we just assumed that would never be an option. And I know that, you know, at Magee, we are doing that work, but it's the barrier to entry. You have to be in a very privileged position to be able to access that. The questions of, you know, minor maturity are ongoing. Even just the questions around gender identity, there's a constant pushback on how can you know what your gender identity is at the age of 5, at the age of 15, at the age of 25. So knowing whether or not you want to have children at some point is very difficult for someone who's never thought about it. There are young people who have. I don't honestly know what the statistics are because, like so many other aspects of gender diversity, we haven't done the studies. But I think if it's accessible, providing the option for that choice later in life is essential. The challenge is that it's not very accessible right now. I personally see a future where fertility preservation goes well beyond those who have an urgent need to those who could potentially have a need, especially as fertility rates drop. I could see large banking of material for anyone who might be in a risky situation or for people at peak fertility who may not be able to conceive later in life. So maybe with you know, the economies of scale, this will become more and more accessible and these questions will largely answer themselves. But the challenges are there. The best thing you can do is do the studies and find out. Thank you.
Thank you, Allison.